Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. Here we have a patient who attended with a fully blocked right ear, and they have a combination of earwax and a lot of dead skin, keratin, and the more medial part of this, so the wax and dead skin that's deeper in the ear beyond what we can see here at the moment. It's extremely compressed against the eardrum and it's quite tricky to remove. So if you stay tuned as we remove all the lateral, more external wax, you'll see what we're faced with. Now, this type of wax and dead skin, it's very difficult to remove because of the consistency, and it has also been compressed. It's very hard to suction this type of wax. It's got this mushy consistency. So I've just put some drops in there, and that just helps change the consistency. It helps to bind the wax, also helps to lubricate the inside of the suction tube. So if there is some wax or skin that's getting trapped, hopefully the oil will help to release it so that the wax and dead skin can travel up the tube. So I'm just hovering over the surface of this dead skin and wax. At the moment it's hard to visualize or appreciate where the ear canal wall is at the base of the ear canal, and that's because this skin and wax, it's almost camouflaging the ear canal. So it's a similar color, but you can see on the right hand side I've managed to peel away some of this dead skin. Now some of you may ask, why don't we use other instruments to remove this? It's just because it's for two reasons actually. It's a bit deeper in the ear, and for me to use other instruments like an ear hook or Jobson horn, for example, I'd have to glide in between the wax and dead skin plug and the canal wall. When you're in the inner 2/3 of the ear canal, you've just got to be really gentle because it's just bone there. It's just the thinnest of layers of dead skin that's coating the bone, less than 0.1 millimeters in thickness. You can just appreciate it's wafer thin, whereas the skin on the outer third of the ear canal, the cartilaginous portion, which is less sensitive, it's more malleable and flexible, the skin's 10 or 15 times thicker, so it's in excess of 1 millimeters in thickness. So it adds a layer of it kind of acts like a buffer. So by all means we can put hooks and scoops in and trying to remove this, but it will be uncomfortable for the patient, and that's the last thing I want. So we're just proceeding with suction. It's just a bit blurry because of the drops that as we go through the procedure, that will clear. I've just wiped the lens as well. So that sometimes it is a bit of a, it can be a bit of an issue when you use drops. You can get a bit of blurriness as you're suctioning, but as the more you suction, the less drops is still in the ear, and it's a bit better. You should get less blurriness. So I've just released the wax plug from the right hand side of the ear canal, and also from the back part. Now we're just at the base here, and I've just about got a suction grip, and I'm just levering this wax plug upwards. Now of course forceps wouldn't be suitable for this, it's just too soft and mushy, and there's also nothing to grab onto. Forceps, you generally use forceps when there's something protruding outwards towards you that you can grab onto, or there's an opening around the edge and the wax is firmer. That's the key. It's all about the consistency. If you've got something soft like this, the forceps is just going to cut through it. It's not going to extract anything. You can see the lovely view that we've got. We can see the whole ear canal, the whole perimeter of the canal wall. So I'm just releasing this dead skin and wax from the back part of the ear canal. You can just see it is like mashed potato. I'm sorry if anyone's having their supper right now, but it's got that consistency. It's really probably the most challenging consistency to remove. So we're probably about more than halfway into the ear canal here. And there's a few hairs that are matted against this skin and wax plug. You can see I'm just slowly going all the way around the edge, just to try to loosen this. I think I'm going to put some more drops in. I think I used drops on several occasions just to help loosen this. And you can see it's coming away from the right hand side. So I've got a sizable chunk out here. But once I've removed that outer layer, this more medial layer, it's got a similar consistency because the drops hasn't really penetrated against this. So I'm going to have to use some more drops in a minute. And sometimes that's the way you remove wax. You have to go in layer by layer. We had a training course at the weekend. I had a double header actually, and I explained to the delegates that to remove wax, you must have, you must be a very patient individual, or if not, you're going to learn to be patient, because there's no shortcuts really, unless you want to cause some trauma to the patient, which is obviously that's what we don't want to do. And sometimes you just have to take it nice and slow. You don't want to compromise the patient care and their comfort. You see that wonderful view that we've got. So this is the more medial bit that's compressed. So I just put a bit of drops in. That's just what's causing the blurriness here, but that will go in a moment. And the problem with this kind of wax here, where I am now, is that when we put the suction probe on, inadvertently sometimes we can push the wax further in against the eardrum and it can be uncomfortable. So again, we'd be really careful here. I'm just hovering over the surface of this plug. I'm looking for a weak spot. I'm looking for something to get some purchase. So I'm just going to the back part here. I'm lifting it up and away. I'm just going back to the bottom. So at the bottom, there's a recess at the bottom. It's called the inferior recess. It's like a basin, a trench, and quite often you can get, when wax is compressed and up against the eardrum, it can get lodged in that recess. And you can see I've just lifted that out of the recess and it got a sizable chunk out there. And again, it's just this, it's never ending really. So you can see we're doing, it's almost like peeling an onion, you're doing it but layer by layer. And this is the, I believe it's the final layer. It's also lodged on the right hand side of the ear canal. That's the anterior recess. I'm going to try and get into that and lift it. So suctioning right to left, just so I can maneuver it out of that recess. I'm going to have to put some more drops in. I think I will do in a moment. And this is why we always recommend people to avoid using cotton swabs or Q-tips, as they're known in America, and in the UK, cotton buds, because you may be lucky and you may get some wax that sticks to the edge, to the tip of the Q-tip, but primarily you're pushing this further in. And this is what this patient's done. You can just see how compressed it is. And I'm at the roof of the ear canal now, the top part, and I'm peeling downwards now to detach this from the eardrum, because it is stuck on the eardrum. So the eardrum's directly behind this wax plug now. And of course, whenever we're working near the eardrum, we've got to be even more gentle and cautious. So I just think I've just put some more drops in. And I'm actually suctioning. One of the things that I've developed over the last year or so, I would say, is previously when I put drops in, I would let it soak and I'll drain the drops before proceeding. And I sometimes still use that technique, but more and more now, I'm actually performing the procedure whilst the drops is in situ. So I've got the patient's head tilted over. This is their right ear. So their head is tilted. So their left ear is towards the ground and their right ear is towards the ceiling. And as such, I'm actually stood up looking down into the ear. And what I've done, I've attached to a fine end suction gauge here. And with a fine end suction gauge, although it's less suction, because it's a narrower internal lumen, it does concentrate the suction power into a smaller surface area. So sometimes when it's really lodged like this, although in theory it's less suction, but because it's more concentrated in the smaller tip, you can get more purchase. You can see I'm just working along this anterior recess and slowly I'm bringing this out. I've just got to be careful that I don't touch the side of the ear canal wall. See, we're millimetres away there, if that. But it's coming away and I've just managed to loosen that. So I've managed to extract that from the compressed wax and dead skin off the eardrum. There we are, voila. And that's the patient's eardrum in the distance. It's slightly inflamed, and that's just because the wax was compressed. And you can just see how narrow the ear canal turns into where I am now. Then it widens back out again. We call that narrowing an isthmus. So I'm just mopping up at the entrance. And sorry I didn't manage to take some still images of the wax and dead skin on this occasion. It was just a very busy clinic. And I hope you enjoyed that video, guys. In the UK, it's a bank holiday today, so I hope everyone's enjoyed their bank holiday and keeping well and safe. Take care, speak soon, and remember, be nice and be kind to each other. Bye.